We recently have had new data coming out with the results of TAVR and SAVR, transcatheter aortic valve replacement, and surgical aortic valve replacement in the intermediate surgical risk population. Those results have shown equivalence and arguably superiority by a transfemoral approach of TAVR versus SAVR in patients that are deemed intermediate risk for surgery. And now clinical trials have started in low-risk patients. Now, as we well know, patients and their referring physicians will always prefer a less invasive therapy compared to a more invasive therapy if the results are roughly equivalent. So, therefore, should there be a headlong rush into TAVR? I think there's a couple of things that are appropriate caveats before we make firm decisions right now. The issues with TAVR are, first of all, stroke. And from what we know, there's rough equivalence between TAVR and SAVR at the current time. Second, there is an increase in paravalvular leak with TAVR compared to surgery. Although this has diminished significantly in terms of moderate to severe paravalvular leak, it's going to be more of an issue as we move into the younger population. The third issue is need for permanent pacemaker. And there's about at least a 2 to 3 times higher need for permanent pacemaker with TAVR than with SAVR. Again, it's not a major issue when the expected survival of the treated population is relatively short. However, as we move into a younger population, and this includes intermediate risk, that is a significant concern going forwards. The fourth thing is durability. We don't know how long TAVR valves are going to last. There's not a major signal out to 5 years of structural valve deterioration with TAVR, but there is some evidence that has come out, albeit not great evidence, that there may be an earlier incidence of structural valve deterioration with TAVR. As we move into younger and younger population, this bears close scrutiny going forward. And the last issue is with valve thrombosis. There have been reports now in TAVR valves, and also to some degree in surgical valves, of valve thrombosis happening in the absence of anticoagulation. This bears close watching. As I mentioned, there are low-risk trials in the United States right now comparing TAVR versus SAVR, and embedded in these trials are 800 patient sub-studies of both TAVR and SAVR looking at the issue of valve thrombosis with 4D CT scanning. So it is an exciting time. There already has been significant risk creep down into the intermediate risk population. The FDA will make decisions later this year about approval in this risk population, but it is an exciting time for patients and their treating physicians.